Hello, I'm going to give everyone just a few seconds to get logged on, and then we will get started. All right, so we are going to go ahead and get started. Thank you guys for joining us. This is the September 2022 RDLA webinar. In honor of September being Newborn Screening Awareness Month, this webinar is going to be focused on newborn screening. If you prefer to call into today's webinar, you can do so using this phone number here. And as you are listening to each of our speakers, if you would like to ask them a question, please type it into the Q&A box, and a member of our team will direct the question to the speaker. And just a reminder for any media that may be joining us, we ask that you formally announce your participation and refrain from quoting any of the discussion or presentations during this webinar. If you would like to use a direct quote, we encourage you to reach out to the panelists afterwards. We also have closed captioning available for our RDLA webinars. All you need to do is click the live transcript button at the bottom of your window to begin. And we also have Spanish translation services available. So to get that started, you can click the link that Shannon is going to post in the chat. And now for our agenda, we are going to start the day with Dylan Simon from the Every Life Foundation. Dylan is going to talk a bit with you all about the VALID Act. Then we will also have Claire Ellis, also from the Every Life Foundation, joining us to talk about state RUSP alignment. Next, we will get an update on the Newborn Screening Saves Lives Reauthorization Act from Debbie Jessup. And Debbie works for the Congresswoman Allard from California. And then last but not least, we will get an update on the Prescription Medicine Answers for Today Kids Today Act. That one is a mouthful, from Ryan Dowback from the Assistance Fund. So Dylan, I will go ahead and turn things over to you.
Great. Thanks so much, Caitlin. And thanks everybody for joining us today. So again, we're going to start with the VALID Act, which has to do with laboratory developed tests. And that has to do with newborn screening in the sense that many of the newborn screening conditions are laboratory developed tests or start as laboratory developed tests. Some are FDA approved, and that's always great to see, but many are also LDTs. And so there is VALID Act has to do with these. And so we want to talk a little bit about the VALID Act and potential implications. Next slide, please. So a little bit of why we're talking about this. So many are aware that within the rare disease community, the diagnostic odyssey plays a huge role. And so it can take on average 6.3 years from first symptom to receive your initial diagnosis. And newborn screening can play a large role within that to help decrease that diagnostic odyssey. But outside of newborn screening, a lot of diagnostic tools, how we regulate that is really important. How are we getting more diagnostic tools onto the market to ensure the fact that we are providing more and more options for members of the rare disease community to receive the diagnosis that they are seeking, to get answers of why they're having the symptoms that they're having. And so diagnostic is such an important part within the rare disease community to ensure the fact that members aren't waiting 6 years to receive that diagnosis, that they can get their answer, whether or not there's a therapy involved. Having that answer can play such an important role. And so again, that's a lot where the diagnostics comes into play. So next slide, please. So a little bit of background on how diagnostics are discussed today. So you have in vitro diagnostics. So these are reagents, instruments, and systems intended for diagnosis. Again, these are typically kits that are regulated by the FDA, and they must go through the FDA approval process, and any changes to IVDs must be reported to and approved by the FDA. And so these are, again, larger systems, instruments as a whole. Any new instrument that is introduced must go through this IVD process, as well as any kit. So if you're looking at a very specific diagnosis process or diagnosis kit where all the reagents must come together and be sold as a unit, that would go through the IVD FDA approval process. Then you have LDTs, or laboratory developed tests. These are a subset of IVDs, and these are regulated by CMS. Within CMS, it's regulated by CLIA, which is Clinical Laboratory Instrument Amendments, I believe. And labs must meet these CLIA requirements before they can develop LDTs. And here, tests can be altered to meet rapidly changing diseases and science without undergoing specific approval. So within CLIA, you have CLIA-approved labs. And so what CLIA is looking for is, is the lab able to do what they say they're going to do? And we're going to talk a little bit more about analytic versus clinical validity momentarily. And so what CLIA is really looking at is they're looking at the full system. They're not looking just at the reagents or the test itself. They're looking at the lab, they're looking at the materials, and looking at, does the test do what it say that's going to do? But because it is regulated through CLIA as opposed to FDA, that last part is really important, the fact that you can update these tests a little easier because CLIA approvals every 2 years. And so it allows for you to update, make sure that the test itself is as up to date as possible. In addition, it makes it easier for individual hospitals to develop individual LDTs that best suit their hospital and their testing methods. Next slide, please. So again, a little bit more background about the review process itself. So again, as I said, within the FDA, they're looking at IVDs and platforms, as well as CLIA is looking at the labs conducting testing on human samples. And here we're looking at validation standard. So CLIA is looking solely at analytical validity. Analytical validity, simply put, is, does the test, can it properly identify the analyte or the substrate that it is looking for? So if you're saying that this test will test the levels of enzyme A, analytical validity is looking at, okay, can you actually do that? Can you actually show that this, you can probably identify the levels of enzyme A? What the FDA is looking at is, in addition to, can you probably identify enzyme A, they want to know if, does enzyme A cause disease Y? And so that's where you get clinical validity. So clinical validity is looking at, does what you're testing for have proven to cause a certain disease? And so again, we're looking at the validation. Within the FDA, you're going through a pre-market review process, which typically includes human studies required to demonstrate the test's ability to predict a disease. So that's where you get the clinical validity. Whereas for CLIA, you're looking at labs must establish performance characteristics of the test, including method validation, patient outcomes, quality assurance, and proficiency testing. And so again, it's a very nuanced conversation, and I'm going to try to distill down what could be a 40-minute presentation into about 10 minutes. And so I do encourage those who have more questions to please reach out to me. I'll make sure that my email is in the chat box after this. But again, this is a top-level overview. And next slide, please. So now we get to the VALID Act, or the Verifying Accurate Leading Edge IVCT Development Act, but VALID Act for short. So this was introduced by both Senator Burr and Senator Bennett, as well as Reps Bouchon and DeGette in both the House and the Senate. And the VALID Act would create a new class of clinical tests known as in vitro clinical tests, or IVCTs, that the FDA would regulate. This would bring in many of these LDTs that we discussed, and they would be, IVCTs would be defined as test kits, systems, test protocols, laboratory test protocols, instruments, and certain software whose intended use is to diagnose a disease or to provide information that will aid in the diagnosis through determination of the individual's health. And I wanted to read that out because it is a relatively broad definition, but it really gets to the idea of what it's looking to regulate is tests that their purpose is to help provide a diagnosis for a condition. Next slide, please. Next slide again. Perfect. So here we're looking at, again, now you can see in the third column how IVCTs will compare to FDA and CLIA. So the bottom right box is getting a lot of information that could be 20 slides by itself into a very small area. And it would create a multiple risk-based pathway to determine the regulatory process for newly marketed IVCTs. I didn't want to dive too much into the nitty-gritty details because it can get very nuanced very quickly. But essentially what the VALID would do is it would bring in most of what is regulated under CLIA, not all, but a lot of what is regulated under CLIA, into this new process. And it creates multiple pathways to attempt to make it a little easier and not as cumbersome as going through a full pre-market review process by creating a risk-based pathway, or high risk, medium risk, and low risk. And the risk is based on what is the risk of getting the improper diagnosis. And so that's how they're defining risk under VALID. And so there are exclusionaires. And so within the rare disease community, there was a carve out for rare diseases to avoid the pre-market approval process. And the reason for that is the pre-market process is a time-consuming, can be a very costly process. And the worry was that if it was too much within the registered community was included within that it would limit the ability for those to address new conditions through diagnostics and development of LDTs. So again, next slide, please. So current status. A version of the bill was included in the Senate version of the user fee package that passed the Health Committee. It is one of the many health policy provisions that will look for inclusion within the year and omnibus package. And Debbie will be talking about another one as well momentarily. And I want to give a quick update. So the House and Senate Appropriations Committee both introduced matching legislation that we are for a continuing resolution that is expected to pass. It has cleared one hurdle in the Senate last night. It's expected to pass later this week. And within that CR includes the user fee package. And I want to highlight that because VALID was included in the original Senate version of the user fee package. And within that, it included multiple policy provisions, including the VALID Act. The House had a similar bill with different policy provisions. However, in the CR, it is what is known as a clean reauthorization for the user fee, which means it does provide a 5-year reauthorization for the user fee program without any policy provisions. In addition, it had 8 programs that often move alongside the user fee provisions, but that actually is mirroring the CR in terms of it provides funding through December 16th. So what that is setting up for is many health provisions to try to see inclusion within that omnibus package, and there are conversations already happening about what to go into there, compromises between that. And so the Every Life requests for continued engagement on this issue before inclusion in a year-end package, because as you can tell, this is a very complicated issue. And we want to make sure that we're talking through a lot of these issues before it gets included in any year-end package. We just want to make sure that we're sorting through some of these nitty-gritty details. And again, I know I provided a lot of information relatively quickly, so I'll put my email in the chat box. And please do not hesitate to reach out if you have any additional questions. But thank you again for your time, and I'll pass it back to Caitlin.
Great, thank you, Dylan. Like Dylan said, if you think of any questions for him, please put those in the Q&A box, and we will get those over to Dylan. So now I'm going to turn things over to Claire to talk to you all about state RESP alignment.
Hi, my name is Claire Ellis. I am the Policy Fellow at the Every Life Foundation. I'm going to talk about RESP alignment legislation. So Caitlin, you go to the next slide. You can go one more. There we go. Great. So before I kind of talk about RESP alignment legislation, I want to really quick talk about what the RESP is and kind of how a condition gets added to the RESP. So the RESP is the Recommended Uniform Screening Panel. It's a federal list of conditions that the Secretary of HHS recommends states screen newborns for. And so in order to get added to the RESP, a condition has to undergo a review process. They have to follow this kind of arrow in order to get added to the RESP. So there is an advisory committee. It's the Advisory Committee on Heritable Disorders in Newborns and Children, or the ACHG&C, that will receive RESP nominations, receive condition nominations. They'll review them and then ultimately decide on whether or not they want to recommend a condition to be included in the RESP. The ACHG&C will make that recommendation. The Secretary of HHS ultimately has the final say on whether or not they want to include the condition on the RESP. There are currently 36 conditions on the RESP. The most recent condition was added in August of this year. That was MPS 2. And GAMP deficiency is currently kind of in this waiting period where they have been recommended by the ACHG&C, but are awaiting final approval by the Secretary of HHS. And hopefully that will be approved and added to the RESP sometime around November. And there's a third condition, Crab-A, that's currently making its way through the review process. And so it's being reviewed currently by the ACHG&C, and they'll make a final recommendation sometime next year. So Caitlin, you go to the next slide. So like I said, the RESP is the Recommended Uniform Screening Panel, which means it is not required. It is just a recommended list, which means states are welcome to add conditions, but are not necessarily required to add these RESP conditions. And so we kind of, Every Life has started a legislative initiative where we work to kind of speed the process and get these conditions added to states sooner. So the RESP currently, it takes about 5 to 6 years for a state to add a condition that's on the RESP to their state panel. And so we're seeking to speed that up. We're seeking to, bring that 5 to 6 years down to 2 or 3 years. And it's also important to note that it takes, I think the ACHG&C says that it takes about 3 to 4 years for a condition to undergo the nomination review process. And that doesn't even include all of the time that it takes to prepare a nomination. So we're looking at, a decade at least to get these conditions approved and added to the states. And so we're really seeking to speed up specifically the 5 to 6 year timeline to 2 to 3 years to ensure that, babies are being screened for these conditions sooner. And so I'll talk more here in a second kind of about the key parts of RESP legislation. But first I want to talk about kind of the advocacy efforts behind RESP alignment legislation. And so when we're considering going to a state, when we're looking at what state we want to pursue RESP alignment legislation in, we're looking kind of at each state individually. I think it's important to know with any legislative effort, every state is different. And so when we're trying to determine where we want to pursue this legislation, we're looking at prior legislation and regulations regarding newborn screening. We're looking at how newborn screening is funded. We're looking at what conditions are being screened for, is the state screening for every RESP condition? If they're not, what RESP conditions are they missing? And, kind of how many are they missing? We're also looking at the capabilities of state newborn screening program, kind of what are they doing now? How can we help, bolster the capabilities of the program? And then the other thing is when we go and pursue this legislation, we understand that RESP alignment takes a village. It's working with patient advocates like you to kind of build that coalition of newborn screening stakeholders to help educate, push the legislation along is really important. We also work with the state newborn screening programs, the Department of Health and public health labs to understand their needs, understand what they're capable of regarding newborn screening. And then finally, again, we're working with stakeholders to educate legislators and move the RESP alignment legislation forward. So you go to the next slide, Caitlin. So when it comes to RESP alignment legislation, there's really 3 key parts. The first is kind of the one I think that's most obvious is the auto inclusion. So it's, the requirement that states screen for or consider screening for any new and current RESP conditions. So we want to ensure that, a state is not only screening for every condition currently on the RESP, but is going to screen for conditions as they're added to the RESP, like MPS 2 or hopefully GAMP deficiency here in the next couple of months. And so when it comes to this legislation, we really, or auto inclusion, I should say, there's really kind of 2 ways that states will go about it. The first is the states require a condition to be added within 2 to 3 years of its addition to the RESP. So it's kind of straight auto inclusion. If that condition is added to the RESP, the state will begin screening for it within a certain period of time. The second is the vote for inclusion. So this is giving the State Newborn Screening Advisory Council or the Department of Health within the state the power to consider whether or not they want to add the condition to the state's panel so they can vote and they may not decide to add a condition, but it gives them the power to ultimately decide to add the RESP condition themselves, but it's really kind of encouraging them to, do that vote. So you can go to the next slide, Caitlin. And so a key part of, and the second part of RESP alignment legislation is a timeline. So we want to ensure that if we are, requiring states to add these conditions, they're doing it within a certain period of time. They're doing it within that 2 to 3 years. So we are kind of cutting down on that 5 to 6 year timeline. So when it comes to timeline, there's kind of, again, 2 ways that it's typically done through RESP alignment legislation, but it's a timeline in which states must begin screening for the new RESP conditions. It's typically done either as a general timeline in which conditions must be screened for. So for example, Mississippi this year, we worked to pass RESP alignment legislation in. And it's a straightforward auto inclusion, and they just have 3 years to add the condition. The second is it may be segmented. So this you might see most often kind of with the vote to inclusion legislation, but it is kind of a segmented timeline in which, for example, the advisory council may be required to add a condition or to consider adding a condition within 1 year. And if they opt to add the condition, it must be screened for within 18 months. So it's still a 2.5 year timeline, but it's broken down. It's requiring that vote. And then if, the condition is agreed to be added, it has to be added, 18 months after that vote. I think it's also important to note that in the kind of vote for inclusion states, some of them have an additional timeline requirement in which they may be required to reconsider voting on a condition every 6 months to a year, again, dependent on the state, and if they opt not to add the condition. You can go to the next slide, Caitlin. So the third key piece of RESP alignment legislation is the funding. So we want to ensure that if we are requiring states to add a condition within a certain period of time, they obviously have the resources available to facilitate the addition of the newborn screening conditions. And so that looks kind of a number of different ways, again, dependent on the state, again, dependent kind of on what is already in place regarding newborn screening. But it can typically look like kind of either working on the existing newborn screening fee. So a lot of states will require a fee to be paid for newborn screening for the screening test itself. That's typically paid by the insurers, but it can be hard to raise the newborn screening fee. So a lot of times that newborn screening fee has to be raised either via legislation or by rule approval, which takes a long time. It can be difficult and really slow the process of adding a new condition. And so through RESP alignment legislation, we may be looking at, pulling that fee kind of approval out of the rule process of the legislative process and giving kind of the newborn screening program, the public health labs, or the Department of Health the power to raise the screening fee as they see fit. We actually just did this in Iowa this year where we had pulled it. Previously, the screening fee had to be raised by a rule process and it was really slow and it was kind of, making it more difficult to add new conditions, and we were able to pull that and give actually the public health labs the power to raise the fee, and they're really excited. I think that will be able to help kind of speed implementation. The kind of other way you may see funding addressed in responding legislation is via budget request. So, if you've got that 2 to 3 year timeline, the state may require that you submit a budget request for additional funds so that you can ensure that you are able to kind of add that condition, maybe address staffing shortages or spacing shortages or kind of whatever you need to fund, the addition of this new condition and ensure that the newborn screening program remains accessible. You may be required to submit a budget request. So you can go to the next slide. Again, breast employment legislation is different in every state. So some states will have additional provisions. Some may establish a newborn screening advisory council. One does not already exist in the state. It may also have some report requirements. So some states may require that they get kind of a report on why a condition has been delayed past the timeline that's required. They may also want an annual status report kind of on newborn screening within the state, or they may want justifications on why a condition has not been added to a state panel. So if the advisory council is required to vote on a condition but opts not to include that condition on their panel, they may want to ask for justification kind of on why that they have not added this condition. So you can go to the next slide, Caitlin. And so this is all of the states. So we have passed restful alignment legislation so far. As you can see, the lightest blue is kind of what we worked on restful alignment legislation in 2022. We're up to 10 states right now, which is very exciting. We are obviously hoping to expand this map and include more states. So we're kind of beginning to gear up for 2023 restful alignment legislation. We'll hopefully kind of have a decision on what states we're going to be going to here soon. Once we do have that decision, I will of course be reaching out to Caitlin to contact all of you so that we can help kind of build that coalition and continue the success and grow, to include even more states past this 10. You go to the next slide. This is my email. If you have any questions, I'm happy to answer any questions now or any questions that come up in the chat. But if you have any questions that come up kind of, after this regarding restful alignment legislation, I'm very happy to answer them. And I'll pass back to Caitlin.
Great. Thank you so much, Claire. And like Claire said, if you have any questions, again, feel free to put those in the Q&A box and we will pass them along to Claire. Next, we have Debbie Jessup joining us from the office of Congresswoman Roy Ball Allard. So Debbie, I will go ahead and turn things over to you.
Thank you for the opportunity to talk with you about newborn screening. It's been my great privilege to have worked on this issue for my boss for the last 18 years. Most of you have heard of her Newborn Screening Saves Lives Act, but for those who are new to the issue, I wanted to start with a little background about newborn screening at the federal level and this particular legislative effort. Next slide. Although the first states began mandatory newborn screening in the early 1960s, and most states had developed programs for newborn screenings by the 1980s, there was no federal involvement in the issue until the early 2000s. At that time, newborn screening tests varied greatly from state to state. Some states screened for as few as 4 conditions and other as many as 50. In 2000, the Children's Health Act authorized funding for HRSA's Maternal and Child Health Bureau to invest in newborn screening activities. With this funding, HRSA worked with the American College of Medical Genetics to develop guidelines for newborn screening, and in 2003 established the Advisory Committee on Heritable Disorders in Newborns and Children to advise the HHS Secretary on newborn screening. But by 2008, only 10 states and the District of Columbia required infants to be screened for all 29 of the recommended disorders. As a result, an estimated 1,000 babies with one of these core conditions went unscreened because of where they were born, resulting in unnecessary disability or death and enormous cost to society. Next slide, please. My boss first introduced the Newborn Screening Saves Lives Act in 2002 to codify the Secretary's Advisory Committee on Heritable Disorders and to establish federal programs that would provide assistance to states to improve and expand their newborn screening programs. The bill also authorized grants to support parent and provider education and to ensure laboratory quality and surveillance for newborn screening. And the bill created the Hunter Kelly Newborn Screening Research Program at the NIH. Next slide, please. The bipartisan and bicameral effort was led by my boss and Mike Simpson in the House of Representatives and by Chris Dodd and Orrin Hatch in the Senate. It took 6 years and 4 Congresses to pass that first newborn screening bill. In the 110th Congress, a second newborn screening bill was introduced by Hillary Clinton in the Senate and Tom Reynolds in the House. And that bill also included a clearinghouse for newborn screening information. Senate hearings resulted in the decision that there needed to be a compromise between the two bills. And so my boss and Mike Simpson in the House and Senators Dodd and Hatch in the Senate negotiated with Representatives Reynolds and Senator Clinton and reintroduced a compromise bill. That compromised newborn screening bill was signed into law in April of 2008, and it changed the trajectory of newborn screening efforts. By the time the first authorization ended in 2013, 44 states and the District of Columbia had required screening of at least 29 of the 31 core treatable conditions. Additionally, parents and professionals now had a centralized access to newborn screening information when they were faced with a diagnosis of one of these disorders. Next slide, please. The reauthorization of the Newborn Screening Saves Lives Act was introduced in 2013 during the 113th Congress by Reps. Roybal, Allard, and Simpson in the House and Senators Hagan and Hatch in the Senate. While the bill passed during the course of one Congress and was signed into law, this was the first indication of a problem that has continued to hinder passage of the bill during the 116th and 117th Congresses. During the Senate markup of the Newborn Screening Reauthorization Act, Senator Rand Paul and others raised concerns about the privacy of de-identified newborn screening blood spots and the need for informed consent for all newborn screening specimens that would be used in research. The bill was able to pass during the 113th Congress with an amendment that prohibited further research pending the completion of the NIH Common Rule revision. The practical implication of this amendment was that it required prior informed consent for the use of any newborn blood spot collected between March 19, 2015 and July 19, 2018, which was the date the revisions to the Common Rule became effective. The scientific implication of this amendment was that it made research using both identified and de-identified blood spots virtually impossible for those 3 years. Nonetheless, the newborn screening bill has been very successful. Today, all 50 states and the District of Columbia screen for at least 30 of the 35 recommended core conditions, and over 12,000 babies are identified each year with one of these treatable rare conditions. The authorization for these newborn screening programs expired in September of 2019. Next slide, please. My boss reintroduced the current Newborn Screening Saves Lives Reauthorization Act in May of 2019, and the bill passed the House in July of 2019. This reauthorization bill included one new provision, a National Academies of Science study on the future of newborn screening in the US, to include what is the federal versus the state role, how to facilitate adding new conditions to the RUSP, and how to get the RUSP conditions adopted more rapidly by states. The Senate bill was introduced by Maggie Hassan and Cory Gardner in July of 2019. Unfortunately, the process has not been as smooth this time around. The Senate bill got held up in committee by Senator Rand Paul, and the 116th Congress ended without passage of the Newborn Screening Saves Lives reauthorization. My boss introduced the reauthorization bill again during the 117th Congress in January 2021, along with her longtime supporters, Mike Simpson, Catherine Clark, and Jamie Herrera Butler. The Senate bill was introduced again by Maggie Hassan, and this time with Roger Wicker in February of 2021. The House bill passed in June of 2021, but Rand Paul continues to place a hold on the bill in the Senate without his provisions being included. So for the last year, there has been no foreseeable path forward in the Senate. Next slide. The problem in the Senate is a recurring objection by Senator Rand Paul, who once again had issues with the privacy provisions for newborn screening research and did not like the final NIH revised common rule. But this time, his amendment would require prior informed consent for the use of any newborn blood spot going forward, despite the fact that the common rule does not require this consent. To put this more plainly, what you have is one man whose objection is holding up a bill that impacts the approximately 4 million babies born in this country every year. Newborn screening is totally a state-run program, but this one senator wants to impose a federal rule on the state-run programs that would involve 50 different states needing to create and fund systems of informed consent for newborn screening tests. Both the CDC and the NIH and all of the advocacy groups supporting newborn screening are in agreement that Senator Paul's provision for mandatory informed consent would significantly damage the potential for any future newborn screening research. Next slide. So we find ourselves in a stalemate. We offered a compromise that would have allowed us to reauthorize all of the newborn screening programs except the Hunter Kelly research program at the NIH. Now, that doesn't mean there wouldn't be research done. We were assured the research would still continue, but without the Hunter Kelly language in the bill, there should have been no reason to attach the informed consent provision. Unfortunately, Rand Paul rejected this compromise. In the Senate, one senator can hold up any movement on any legislation just with the threat of a filibuster. That's ridiculous, of course, but because they never actually stand up all night and filibuster, but the Senate rules allow them to shut things down with just the threat. So now we are running out of time, and my boss will be retiring at the end of this Congress. It is breaking our hearts that we may not be able to get this bill over the finish line before she leaves Washington in December. Next slide. So what can be done at this point? We need everyone's help. We're asking every person to call their senators and ask them to pass the bill out of committee on a majority vote. With all the Democrats supporting the bill and many Republicans, this should be possible to get done, and committee passage is not impacted by filibusters. If the bill can pass out of committee, it strengthens our request that the bill be attached to some must-pass final package before the 117th Congress ends. Attaching the bill to a must-pass package, an omnibus legislation, or any of the other end-of-the-year bills, eliminates the ability and the will to stop its passage through a filibuster. It's a long shot, but we have to keep trying until there is no more time. Because if the bill does not pass, then the entire process must start over again in the 118th Congress. And unfortunately, my boss will not be there to lead that effort. So I thank you, and I'm going to turn this back to Caitlin, and I'm happy to answer any questions.
Thank you, Debbie. I really appreciate the thorough background on this legislation and the update that you gave us. If we have any questions pop up, I will let you know. But for now, we are going to move on to Ryan. Ryan, I'll turn things over to you.
Caitlin, and thanks to the EveryLife community for welcoming me today. And it's nice to see a few familiar faces that I know are on the call. So, Caitlin, if you don't mind moving to the next two slides. And thank you. So I'm talking today about the Precision Medicine Answers for Kids Today Act. So as has been mentioned a few times, this legislation is a bit of a mouthful in terms of a title for a bill, but it's very important in terms of reaching a diagnosis similar to a lot of these other things that we're looking at with RUSP and newborn screening and the other pieces that we've discussed here today. So as I'm sure many of you know, some DNA sequencing history goes back about half a century ago, and we can even start to trace back where these tests are coming from to the 1990s when we're looking at NIH's Human Genome Project. And their goal to fully sequence the human gene, the human genome. So I would like to kind of discuss how these tests are great at doing a lot of different things. You're able to diagnose more than just, you know, pediatric rare populations, but what we're going to talk about today is why these tests are important for those people in particular, and these patients. So when we're going to be discussing today these tests, we'll be talking about three main diagnostic tests in particular. So we're going to call them whole genome sequencing, whole exome sequencing, and gene panels. And I will get into them a little bit in the next slide on what the difference is. But in particular, we can really do a lot for our pediatric patients who are suspected of having a rare disease caused by a genetic change, but are unconfirmed and are going through the diagnostic odyssey. So one of the most important things that I think many of us are familiar with from experiences with the diagnostic odyssey is just how important it is to have timely access to a diagnosis. And that's what these tests are for. They're able to really speed up the time in which a patient is able to get a correct and accurate diagnosis that can be life-changing in many circumstances. And that'll just ultimately lead to setting up a better care plan and figuring out other intervention ways to best support these children. Next slide, please. So when we're talking about each type of test, the whole genome, the whole exome, and the gene panels, there's a little bit to be known, which is that these tests are not universal. They're always a little bit different, and they're made by different different labs, and they're sequenced in different places as well. So you'll always have, even when we're talking about a whole genome sequencing test, slight deviations and differences between the different tests that are offered. And there's really, frankly, hundreds of these tests available. So what we wanted to do with this legislation is something that was important, which was to not prioritize any test over another. So whether that be a specific type of whole genome test, or whether that be whole genome testing as, you know, as it is in total. This is really important because we think that allowing the physicians who are treating these patients on a day-to-day basis and allowing them to order the tests that are most appropriate for their individual and specific patients goes a really long way towards making both the physician and the families comfortable with the decisions that are being made on their child's healthcare, but it also allows us to find cost-saving ways in different things. As we'll see on the next slide, these tests are not always the same price. But the biggest difference between the three types of tests that I've mentioned is both how much of the gene you're looking at and how many times that you're able to run it or sequence it as a result. So we'll call the depth of sequencing about how many times you're able to read the nucleotide of the DNA and compare and contrast and see where you think the variation in the genetic code might be. And the more times that you're able to run that test, the more accurate you are, and the more likely you are to find what exactly is the variation in that patient's genetic code. But there's also the element of how much of the DNA are you looking at. So if you don't mind, Caitlin, next slide, please. So as we can see on this little chart, which I hope is helpful to much, this was published by the NHGRI through the national, I'm blanking on what that abbreviation stands for right now, but if anyone has any follow-up questions on this, I'd be happy to flag this. And this was a resource that was shared through the federal government and kind of does a simple breakdown of a little bit of the differences of these tests. So as you can see with whole genome sequencing, like the name says, you're looking at the entire genome, and so you'll be looking at a whole lot of information, and you won't be able to necessarily read it as many times, but you're casting a very wide net. And this can have a lot of impact in terms of, if you don't necessarily know where you're starting, this is a great place to initially start and to get those records get those records gathered. When we look at whole exome sequencing, you'll see this is where the proteins are built. And so it's a much smaller range of your DNA, but it's still very important. And then when we look at a gene panel, what we're seeing is that we're looking at places where we know that there's a symptom that has already been diagnosed. So for example, one of these would be, I'm blanking on it, but one of these would be if you have already been diagnosed with autism, being able to know that has impacts on certain parts of your DNA already, and looking at those kind of coding areas to see, because you have that other symptom already, what else, or what might be the underlying reason that's causing it. And so as you can see here, these tests vary in both how much time they're able to get you a final diagnosis, how much they cost, and how available they are in the market itself. Next slide, please. So as we're talking about access to these tests, we understand that there's a lot of issues around access in terms of both commercial plans and state Medicaid plans as well for these pediatric populations. But we really wanted to focus on working at the federal level to incentivize the usage of these tests in both commercial plans and state plans as well. So legislative efforts began a few years ago when there were some bills first introduced. Eric Swalwell and Scott Peters, two representatives from California, have really been the leaders on this issue, and they've had different legislative efforts get introduced and have slight differences. And one of the things that we recognized towards the end of 2020 was that it was going to be very difficult to have any sort of legislative movement, particularly in the House and in the Energy and Commerce Committee, if there were two members, especially Democrat members who were trying to lead this and weren't able to agree on what the best approach was. So one of the things that we did this year was lead a group of rare advocates to sit these two members down and figure out a compromise legislation. And that's what the Precision Medicine Answers for Kids Today Act is. It was introduced last November, and it was included in the Cures 2.0 as well. So next slide, please. So some of the things that this bill will do are expand a previously 5-state demonstration project to 15 states, while maintaining that this demonstration project would last for 3 years and would provide full federal assistance to cover the costs that states are bearing in terms of their whole genome, whole exome, and gene panels. It also requires the states that are participating in the demonstration project to provide data on the diagnoses that are obtained, what the results of this will mean for future coverage, and the impact of these tests on health outcomes. Additionally, states will be prioritized if they can demonstrate an underutilization of these tests currently. Another important piece of this guidance is that it would direct, of this legislation, is that it would have CMS issue direct guidance to the states to encourage them, but not require them to increase their coverage of these genomic and genetic testing services. And so this is really important, and we think this would go a long way in terms of addressing some concerns that states should already be providing these tests, especially under the early periodic and secondary diagnostic testing, the EPSD program, and some of the requirements for newborn screening in that. And this is a piece that has been included in some of the House Labor HHS discussions in terms of potentially being a part of an end of year package. Just getting that guidance alone, I think, would be a massive step, but the demonstration project would go an incredibly long way as well towards delivering access to some tests right now and being able to pick up the tabs on a lot of families in need. The final piece of this bill is that there's 2 surveys. One of them is a 3-year study done by CMS on all 50 states to examine the current coverage and claims analysis from states. So looking at things like coverage and reimbursements, denials and justifications when folks are not getting access to these tests and other barriers to access. And then a National Academy study that would focus on the patient outcomes and really look at issues around preventative care, health disparities and different pediatric populations and how these tests would be able to impact them. But moving on past what this bill would do, we're looking at, what are these steps that we can do to finally get these into law. And one of those ones that I talked about was the CMS guidance that we'd be looking to potentially get in at the end of year package this year. We know that Congress will be funding the government at the end of this week, but that'll be just a continuing resolution without major changes to it. So anything that we'll be looking for will most likely happen in the lame duck session or in December this year, kind of before Congress wraps up. And we're looking at both getting this bill potentially included. We're looking at how are things moving with Cures 2.0, since this bill is included as a part of that larger legislation. And we know that Fred Upton as well is retiring this year. So seeing what his final priorities and agenda includes, maybe this does include the Precision Medicine Answers for Kids Today Act. Otherwise, I think we'll be looking to take similar steps next year to increase access to these tests and really be able to deliver these tests, and so we can start to use and acquire more data on some of the things that we would be looking for to justify and show states why they should use these tests more frequently. But next Congress goals include getting Senate introduction of a similar bill, trying to make sure that is bipartisan as well, so that it has both Democrat and Republican sponsors, and then looking as well to continue to build the patient community awareness for this issue, and coordinating with some of the states that we're already seeing that are doing similar things. Now we look at Project Baby Bear with rapid whole genome sequencing, which is great. It's fantastic. It's similar, but this is a little bit different in the sense that these are not NICU and PICU patients that are in the hospital and something's wrong when they're delivered. We're talking about kids who may not show symptoms for a couple of months and have already been discharged from the hospital and start to not meet their developmental benchmarks and are falling behind. Now we're looking at potentially evaluating what rare diseases they may have and starting to evaluate them at that point and offering these diagnostic testing. So I think there's a lot of great ways that we can continue to engage, and I'd love to hear from more folks and continue to work with those in the community to strengthen both this legislation and also build more support for this crucial need for so many patients. So looking forward to any questions that folks may have, or if people would like to discuss offline.
Great, thank you, Ryan. I don't see any questions now, but if you could put your email in the chat, just for anyone who is interested in reaching out, that would be great. All right, so our next RDLA webinar is going to be on October 20th. It will be at noon. If you are interested in presenting on a future webinar, or if you have any topics that you're interested in us inviting speakers to cover, please reach out to me. My email address is here on the screen. And of course, please keep in touch with us. If you're not already signed up for our newsletter, you can go to rareadvocates.org and get signed up. This is where we will be able to send you updates on current federal and state legislation, as well as new and upcoming resources for the community and free events. We also have our action alerts on our website, so please check those out. You're able to basically just send a pre-typed up message to your member of Congress, and they are topic based. So you are able to pick different ones based on the topics that are relevant to you. Also, please follow us on social media to keep up with what is coming up in both RDLA and at the Every Life Foundation. And then again, if you need Shannon or I, you can find our emails here. And last but not least, thank you to our Newborn Screening Awareness Month webinar sponsors. We appreciate them, and we appreciate you all for being with us. So thank you guys for joining us today, and we will see you in October.